start off with a very easy conversation. And as we've said, the goal today is to be as free as possible. So I'll want us to get to know our panelists as we take off. Tuko pamoja? And I want you to even think about some of the questions that may arise as we discuss, and you can be able to write them down. We'll give you an opportunity to ask them later. So I'll start with Miss Victoria. So we have heard you're a clinical psychologist. Would like to know what else do you do and what makes you tick?
I love reading. There's a book which was started in 1922, which I'm still reading currently. How many have heard of Reader's Digest? Reader's Digest, a very nice little book. It's got everything that you just want to do when it comes to reading. Unfortunately, I've tried to inculcate the same behavior in my children, but they're Generation X, so they will not read physical books. So if you've heard of Reader's Digest from me right now, go Google it and you'll fall in love with it. So away from clinical psychology, I love reading.
Wonderful. Now, I want to hear from Grace. So I think when we talked about 25 years of experience for Dr. Josephine, my assumption is you were not born. Maybe you can tell us if it's true or not. There's a mic right there next to you.
Yeah, true. I wasn't born yet. I'm 20 years of age. Yeah, and yeah, I'm excited to be amongst you people today. The young people, I know probably there's some 20-year-old seated somewhere, some 19, some 21-year-old. And I just want to tell you that you actually seeing me here means this space is created for you to speak matters of mental health, and that, yeah, I hope my experience will be able to stem something out of you. Maybe there is something you've been keeping, you've really not had the voice to maybe speak about it. The parents as well. I know you're going to be able to see your role, or rather part of what you play in your children's mental health from my speech. Yeah. Thank you.
Wonderful. Thank you so much. And let's give her a round of applause. So, looking at myself when I was 20, I think I was courageous or brave, but not to this extent. Not like this. No. So, we have to really applaud her. Another thing I'd like to let you know about Grace is when we were advertising and looking for people to partner with us to have this conversation, she's among one of the people who showed interest, expressed interest in being here and telling her story. So let's give her another round of applause. And then I'll go to Dr. Josephine. Now, Dr. Josephine, I'd like to know, in these 25 years, you could tell us, just give us a sneak peek of how the journey has been as a child psychiatrist and what you love most about it.
That is, hi. Now, that's a difficult question, but I'll try to do my best. When I was a medical officer intern, I did my internship in Kakamega. And my experience in the pediatric ward, as we were doing the ward round, I would see about 100 children, and you start the ward round from 8 a.m. and you end up finishing at about 4 or 5 p.m. Now, in the middle of that, you'll find that several mothers will be running to you. Daktari, my child is dying. My child has collapsed. My child is convulsing. The experience was not nice because I had wanted to do pediatrics, but that changed my mind because it was almost like trauma. But as a doctor, you know, you can't ngumu. So I continued, and eventually I explored what else I could do after internship and working as a medical officer in several hospitals in this country, then I knew I would deal with children in a different way. That's why I went to do a master's in psychiatry and then eventually subspecialized in children and adolescents. So sometimes experiences are the ones that guide you to be where you are. Now, within this journey, sometimes it's good, sometimes it's bad, but I don't regret having done child adolescent psychiatry because children don't lie. But the adolescents is a different question. So these children and the adolescents have been my textbook. The textbooks that we refer to, that's just theory and guidelines. But my textbooks are the patients, and I still learn from them. Thank you.
Wonderful. To kick off this discussion nicely, we want to hear from the principal. I don't know how many of us remember the experience with the various high school teachers. So I brought one so that in case there are also any lingering questions from back then, we can bring them forward right now. Cindy. So I'd like to know, first of all, two-part question, Dr. Rose Ngondi. So I'd like you to tell us briefly about your experience, especially teaching adolescent, and you told me you've taught adolescent girls for a long time. And then you tell me how that has worked out transitioning now into the clinical space. Are you seeing them the way you were seeing them previously? Yes, just shed some light.
Thank you so much for this opportunity. I was a deputy principal, not principal.
Huyo ndio alikuwa anapiga watu, si ndio? Disciplinarian. Very good. Hata yamejichomea zaidi. Tuendelee.
But I want to believe I was a deputy principal who was different in the sense that my focus was not to punish, but to correct. Yes. And why do I say so? Because I could punish my girls. Up to today, I call them my girls. I taught girls for the 17 years. I could punish my girls, and they could still come back to me for more help. So for me, that was a plus. And it was a good experience. And the reason why I decided to pursue clinical psychology is because you all have a picture of your deputy principal. It's about discipline, running after girls, making sure things are done. At times I would wonder, why do my girls behave the way they behave? Why? I wanted to understand the behavior, the factors resulting to the behavior, because this time she's a sweet girl. The next time, she has done something you can't imagine. And I think the desire to understand the behavior is what made me do counseling psychology at my master's. But I still felt I didn't get it. I wanted to understand the abnormal behavior. And that's why I had to now pursue and do clinical psychology. And I must say I'm honored to share the platform with one of my teachers, my mentors in that area. I'm so happy. So basically, it was a good experience, and it has actually given me an understanding of young people. I have a heart for young people. I would want, even if I met a girl with color red, green, purple, hairpiece and dress up to here, I want to understand what is behind all that. I don't judge what I see because there is a story behind it. And that story is what matters.
Very well. What are these things that you saw? And perhaps you can relate them to what is currently happening. What are these off traits you saw? And what we could talk about signs and symptoms or concerning behavior among the adolescents.
Okay, one of the things that I saw is the aspect of bullying.
Okay.
And I came to learn a child that bullies, more often than not, they were bullied. So I would want to understand, why is this Form 4 girl bullying a Form 1? And now, in the course of that, I'll find myself doing clinical intake, what we call clinical intake. So I'm getting the history of the girl. So as much as I will punish that girl, I have a better understanding about the child, and that's why I would have the parents come in. So basically, anything that you would regard as not normal. A child slapping, a child being very angry, a child fighting with a teacher, a child fainting before they come to school during opening day. You know, those things that you see, those are the red flags that there's something. Okay. A child who was performing so well, all of a sudden the academic performance starts declining. A child who used to be talkative and all of a sudden they are withdrawn. Those are some of the signs that would tell you there's something that needs to be investigated.
Wonderful. I want us to continue on that same path. And Victoria Rika, I'm sure you see a lot of these children during your day-to-day practice. What are some of the things or how some of the ways that we see these adolescent teens present to you?
Dr. Ross has pretty much mentioned that when she would notice those change in behavior with the children in school, she would do what we call clinical intake, history, right? Maybe she was not doing it as thoroughly as she's doing it right now, but she was checking into the background. What are the parents saying? Maybe the child has become very isolative, right? There is the teenage behavior, what we call the usual, where the teenagers lock themselves in the room, they don't want to be with the rest of the family. But there is now regular teen behavior and teen behavior which now tells you there's a problem. So that isolation. There is, of course, if you've been following the NACADA reports, the substances. You know, they say the mean age of use of substances is around 16 years. So maybe the child is also using substances. Then maybe there's just some change in behavior in terms of who are they hanging around, the crowd they're keeping, their peers. They get lost, they go to the mall, they're spending too much time outside. Performance in school has dropped. They've become very argumentative. They talk back at you. You know, those are some of the things that parents come and tell you. But remember, there's what the parent is telling you and what the child is also telling you, which is why now we go back to the family history to take both into context.
Wonderful. I think there's something that's coming out. That even as we listen to what the parent is saying as this child is presented, there's a very unique aspect that then determines how we move on with this case, right? Which is what the child is feeling and what they are going through. Are we right? So I'd like you to take us through, Grace, just an experience of your adolescent days. I know now you're in university. Now you're the one who's leading at the front as a mental health advocate. But I'm sure as we were discussing, you told me the journey did not begin there. So you could just give us a brief highlight of what happened, how the journey was.
I'd talk about 3 experiences maybe. 2, I would want the parents to give an ear so much onto maybe what I'm going to talk about as part of my lead experience. And yeah, the teens, you can equally look at yourself from that point of view. So 1, parents here, how many have nannies at home?
Nannies.
Nannies.
Yes, house manager, nanny.
I can see a number of hands. Literally, kwa kila row, I've seen maybe more than 5 hands. So, yeah, as an adolescent, I experienced some, sometimes you don't really know. You have a nanny, you leave your children with them when you go to work in the morning. Perhaps you're so busy that when you leave home in the morning, the children don't really get to see you. Ukirudi jioni, they are probably asleep. And so like you've entrusted all those roles onto the hands of the nanny. But something we don't talk about, I don't really know if you get time to talk to your kids. For me, I experienced pain and some emotional I don't know what to term it as, damage or whatever, but niliteswa na nani wangu. But now being that she had taken care of us for so many years, ever since we were kids, it was so hard for me to even make my parents now trust that this nanny is actually doing this to me. Then being a kid who has always wanted to do things for herself, I don't really, okay, that was then until I learned. I won't really want to overwhelm maybe my parents with some other things. I would take myself as, you know, the strong one, like Gracie, we can actually do this. We can get through this. Yeah, so that being one of the experiences. Then another thing, growing up and even until now, when I see like the youths here, I don't know, I could just see it from your faces. I know there are high achievers here. There are people who are over ambitious. Hapa, my friends call me Jack of all trades. Like, I could do so many things at once. I'm an entrepreneur. I'm a mental health advocate. I'm a student doing a course that needs too much of my time. I mean, I just, like, you know, try to, yeah, I was the one who always wanted to be perfect. So mostly in my high school and primary, I had a routine. When I wake up in the morning, even now I came here with my journal for this year. So when I wake up in the morning, I draft, this is what I want to achieve at the end of the day. And something is that I didn't focus so much on the progress. I always wanted to feel the impact of whatever it is that I wanted to achieve, that when the day ends and I'm going to bed, I've literally done all of it, but I can't feel the impact of actually me doing all of it. And I would cry. And my friends, the few friends I had, they will be like, what's up? I'm like, you know, this is what I wanted to do for today. I've done it, but I don't really feel like, it's like sijui kitu. I don't know anything. So yeah, the turning point is now when I realize even that progress matters a lot, that showing up matters a lot. Yeah, you don't have to feel it all at the end of the day. It could come after a long time. Some goals we set are long term. You could not feel it after the 12 hours of contact in a day you've had with your teachers, you've had with your classmates, with your friends, higher achievers like you. And so, yeah. Another thing, most important part, I think it integrates a lot with the nanny thing. Turns out both my parents at that time, they were heads of institutions like Dr. Rose. My dad happens to be a high school principal. My mom as well, but she stepped down for a bit, but she's now a lecturer for reasons to do with mental health as well. So I hope you'd understand it's not really just a focus on the teen, on the youth, on the young adults, even our parents themselves. Yeah. So, yeah. By the virtue of the fact that now they're heads of institutions, that means even Dr. Ross, I don't know how you'd go about that, but it means you're not at home all the time. Yeah, for you to be home maybe on the weekend, you strive kumaliza your duties on Friday evening so that you come home, ukae na the kids, you only have time to spend with them on Saturday. again, issues could arise on weekends that would necessitate you to now go back to school so that you check on the other students. Yeah, so that is what would happen. And my dad apparently worked like very far. So the only time I would see him was on Fridays. But my mom happened to be in a school a bit nearer. So she would make time daily, but not, it wasn't much because she was equally busy. She would take like some 2 hours, come home, we interact for a bit, but she really didn't know whatever it is that was going on. So them being busy, at some point, 10 years of age, I was like, I see them strain a lot because 10 years of age is now after my mom realizes whatever my nanny was actually doing, and she's fired. She's trying to now create space for me to actually be the girl who speaks when something is not going right, and not actually having it within myself or seeing to it that, I can know how to handle it. I know how I'm gonna handle it. So I'm like, now I see my mom struggling with nannies. It's like ameona tu kitu kidogo that maybe to me didn't feel like, being oppressed or something, out wanaenda. So I'm like, how about I go to boarding school? And I insisted so much on it, so I went to boarding school.
Grace,
Yes.
I want us to hold there where you go to boarding school. Thank you so much. So I want to ask Dr. Josephine. She said a few things that I think from our discussion I know are important. The aspect of parents being present and how that contributes to what we're seeing potentially now.
Yeah, now she has said something very, very important, the presence of the parents. And as I was doing my introduction, I told you that I went to do mental health for children and adolescents. And one of the things that guided me was that I wanted to be available for my children so that I can take them through life, so that I don't blame myself for not having been available. And I think it helped me. But going back to her experience, is the parent must be available through and through. It's just unfortunate that mother and father have to work to bring food on the table. But if it were my wish, I would rather the mother is at home and is paid for being at home.
Hey.
So that, yes, or the fathers who are working, then they are paid double to cater for the mothers who are working. Those mothers who are here, I believe, even if you are working, you do double work as compared to your spouse. You are the first one to wake up and the last one to go to sleep. Am I right? Yes. So, unfortunately, with the young girl's experience, as parents, we go through life as we bring up our children in a more of auto mode, where you deliver, you breastfeed, the child grows up, go to school, come back, they are growing up, boarding school, university. It is not like that anymore. It cannot happen. My parents, my mom had to be there until such a time, but that I knew myself. But for the current, the mother has to be there and know the child right from the beginning, because there's a reason why. These children, there are four aspects of development. We look at the physical aspect, where the child grows up, starts walking, running. Then there is the social aspect. There is the emotional aspect and the cognitive aspect. Unfortunately, The system only focuses on the physical and the cognitive and leaves out the social and the emotional, such that even when these children are taken to hospital, where physical examination, the child is okay. Oh, mommy, your child has no problem. We have not taken care of other aspects. And that's why this young girl was going through a very difficult time. Availability to look and see. There's something in psychology called mentalization. Mentalization is the ability to read the other person's mind. Now, that starts right from the beginning when the child starts breastfeeding. And in the process of breastfeeding, in fact, I'm meeting mothers who are not even breastfeeding. They say, maziwa ilikauka. Ilikauka, why? There's a reason. There's stress, there's pressure. There are so many pressures that are acting against the breastfeeding. Now, so that breastfeeding aspect, the first 6 months, the nutritional aspect is so important. But after that, the bonding where the child reads your face and you also read the child's face. But what are we seeing? The mother is breastfeeding, but is on. The child will bite the nipple. They must complain. So the concentration must be on the child because it is doing something. It helps the child to emotionally regulate. It helps the child to socialize and to be responsive. So with the subsequent development, you've already developed an attachment. Now what happens when the mother is very busy? The child is left under the care of a caregiver. Now this caregiver, there is assumption that she's like the mother figure when you're not there. But she doesn't have the skills that you do have. She doesn't have the child's interest, all the interest at heart. She doesn't have. She is employed to do 1, 2, 3. And akishamaliza ameenda. So what happens to the child when she wants to cry that so and so pinched me, I did not get what I had planned to do by the end of the day? Whom does she cry to? Because the house help is not available. Ako askari mwingine kwa nyumba. So nobody listens to this child and problems start from there.
I like the way the conversation is moving, and I want us to direct it in that way. I want us to unravel it slow and slow. So we've picked up, there's an aspect of bonding and presence that is key in terms of development and upbringing. And Grace had now touched on another part that I want us to look into. And I want us to look into it carefully. So in 1 minute, Grace, so tell us about your boarding experience. You've now started boarding school at 10 years. Go.
I joined boarding school. I realized it later. Even my mom says, like, you're so understanding. I'm a last born, by the way. So she's like, you don't even look like a last born. You don't behave like you're very understanding. So a year after joining boarding school, my mom steps down from being a high school principal for some reasons. Mind you, it was my 5th school. And
5th school?
5th school, yeah.
Oh, why had you moved from one school to another? Just in brief.
Still my parents, any little thing I would report, like now things are not going right here. Tunachapwa sana. We moved to another.
You moved to a new school.
Yeah.
Oh, I hope you're taking notes, principal. Mambo hapa ni moto. Hiyo story ya kuchapwa. Tell us. So 30 seconds, yes.
Turns out this school was one of, those most prestigious schools in our county. And my dad was convinced if I take my daughter here, she's going to come out successful. Atapata 400. So I go to the school, my mom steps down. So I'm like, if I didn't come here, ange step down kama bado niko na yeye, and at least now I can have time to be with her. But I don't equally want to tell my dad that sasa I want to step out of boarding school, because atakata, he knows that is the best place for Gracie. So yeah, nikaanza develop some very bad habits that we were talking about in the morning with Dr. Rose. I would pretend I'm very sick. My dad comes, picks me at school. Tunaenda home nakaa 1 week. He's like, are you okay now to go back to school? Now it worsens. Yeah, so tulizunguka kwa madaktari. We walked around. He's trying to figure out what's going on with my girl. So yeah, I was referred to a pediatrician, and I was just pretending of, some GI distress problems. And I was even done for a test on endoscopy so that they were able to, what is this that we cannot find out? And at the back of my mind, I know, like, Akuna. I just don't want to go back to that school. So now that's where the importance comes in as well in mental health. And I was asking them, are these clinicians, are these doctors, are they pharmacists, are they trained enough for them to actually know, okay, yes, there is a diagnosis, but we can't really see what's wrong with this patient. Does their mind shift to actually seeing that this could be a mental thing, and now them being referred to a psychiatrist? So my pediatrician realized that, and now that's where my parents came to now understand the importance of, counseling and all these other aspects that have to do with mental health. Then just to say, in my field of pharmacy right now, I get to study so many classes of drugs, and some of them have to do with the CNS, these mental things. So my relationship with my parents have actually improved in that I saw my mom use these drugs at some point, and someone said, like, there's nothing, as you see, you could be studying as a doctor, people who are in the medical field, you could be doing something, and someone who you love who actually went through that or actually used that you're learning, and it's so hard. And so there's this constant, you want to concentrate so that so that you help them. So those are what my conversations with my mom are made of. When she tells me of her experiences when she was facing depression and all, I tell her about this. She's like, oh, so that's why, yeah. So
Okay. Thank you. So in medical terms, by the way, I am a doctor, a real one. We call it somatization. And I'll give my personal experience before we go to Dr. Rose Gondi. So this is 5 years ago. I was working in one of the ICUs in Nairobi. And one of the most common things we had in the ICUs, usually you could classify this class of diseases that you see. So very bad road traffic accidents. Then there was a very unique, or people who have advanced cancer. Then there was a very unique population, some very young girls. And usually they would come unresponsive. Okay? So a 12 to 17-year-old girl, they come unresponsive. So as doctors, we are taught that if you're not alert, we inflict some pain so that we arouse alertness, correct? So usually we have very painful techniques of inducing pain. Very painful, my friend. So one such technique is pressing on the angle of the eye, or rubbing the chest, or pinching very, very hard. Now, I want to put it to this audience that this 14-year-old girl showed us shege. Because you've gone in for your shift. This girl is not moving at all. So you go, you pinch her very nicely. She does not flinch. You press the inner angle of her eye. She does not move. And she came in because she has been unresponsive for over a day. So ideally, she should not be alive, correct? So there we are, a team of doctors, and we are not clear what is happening. We do not know what is happening. So as we were discussing, and we had to put her in her own separate room, we noticed, so we couldn't discuss. We realized every time we discuss in the room that she is in, the following day, something relating to what we discussed would happen. So now we discovered here, tunachezwa. So we went to discuss outside, and someone was left watch at the door. So the minute we walked out, the young girl would open her eyes, alafu anaangalia kando. Then when she sees us moving close to the door, she plays dead again. And I want to tell you that she did this for 5 days. And she was in the ICU. By the time all of us were caught flat-footed like that, it was 5 days into the period. The parents were paying an ICU bill every day. The girl was in a lot of pain every day because, every doctor who comes does the same thing. And she did not flinch. Dr. Rose, what did you see? I know there are very many stories around this.
My experience, one of my girls lost her voice, and she had come from another school. And the reason why she came to our school, she was transferred, is because she didn't like her school. But when she came from this study, that's what we call conversion disorder. Convert centimeters to meters. So they convert emotional distress into physical symptoms. Correct. That's what happens. Then the other one that I witnessed was paralysis. The limbs can't move. They move. Completely locked. And painful. You have to hold that child strategically.
Yes.
Even putting them in the car.
Yes.
You have to be strategic.
They can't
yes.
move.
And you can't stretch the legs. So you organize yourself. And you see the pain and the frustration of the parent and you feel it. The other one is fainting. And fainting at a particular time.
Yes. Move your mic. Very close. We want to hear this story about fainting nicely.
Yes.
I know it affects many of us.
Now, fainting, what happens, because you also have to put a disclaimer. There could be a medical reason. You need to put that disclaimer. And what we are discussing here is what we call psychosomatic symptoms. Someone has physical symptoms that have no medical cause, but that can only be ruled out by a doctor. Then the other thing also is fainting, whereby children, and more often than not, my gut is not to faint, is students will join us who would have psychosomatic symptoms because my gut already knew they can't faint.
It's not allowed.
Actually, that's when I remember I said one student asked me, teacher, how come when we carry these people to the clinic, after a while, they come back? You don't take them to hospital. But now this one, you must observe the pattern of fainting. Someone who is having what you call the psychosomatic symptom disorder, if they fall, they don't have themselves.
Yeah. It's a strategic fall.
It's a strategic fall.
Strategic.
Yes. Number two, they will see a pattern.
Yes.
They will either faint the day they're opening. You have to observe a pattern for you to say this is not medical. Yes. So those are some of the experiences that I saw, but my greatest pain, doc, is to see the frustration with the parents.
Yes.
And as she has rightly put it, moving from one hospital to another.
Yeah.
And that is money spent.
Yeah.
That is time spent.
Yeah.
And allow me emphasize what she has said. Parents, and also what Doc has said. Parents need to be present. If you are not present, imagine they will force you to be present. And And you will come, whether you like it or not, I will call you to school. Because if your child has fainted, I can't do nothing. It's you to come and take your child to hospital. And once you take them to hospital, you know what happens? They come back with the medication. Do you think they take it? No. They have achieved what they wanted. Go out, take chips, sausage, I am back. And let's continue.
So, Dr. Victoria, Victoria Rika, I want you to tell us, what are some of the things from a clinical psychologist's perspective? When these parents come to you, they tell you, this is what my child has been doing, as we've been describing. What advice do you give them, or how do you walk with them through the journey of that scenario?
We've already mentioned that about the presence of the parents. You know, parents, you don't have a choice. And I was thinking, as she was talking about the nanny, I'm sure most of the mothers mentally went home trying to figure out what's going on between my baby right now and the nanny back home. But as parents, we do not have an option. I have handled, unfortunately, adolescents, one of them who told me, my parents are never at home. They are high flying. They actually drop one suitcase at the airport. The driver takes the next suitcase with the next change port. So they never get to see their children. They never get to see their parents, rather. But how do these parents compensate? They buy them the latest gadgets. They give them their own credit cards. It's not what the children want. That is why they do it, because they want the parents to be present. But what we tell the parents, you must create time. You must be intentional to be in the lives of your children. If it means sacrificing one day in the week, maybe over the weekend, to spend time with those children, to talk to them about the issues they're going through in life. I tell the parents of my children that if you lost out on creating a bonding experience with your children, when they are growing up before preteen, it becomes very hard for you to create any relationship with them when they're in their adolescence. Why? Because at that point in time, they are more invested in being with their peers than in being with their parents. So you kind of lose them. But before preteen, bond with them. And how do you do that? Is also through things like communication. How do you communicate with your child? Most of us suffer from what I call intergenerational trauma when it comes to parenting. My parents parented me in some sort of way. I was beaten. Therefore, it must work on my children and they'll turn out right, which does not work. You must go back to yourself as a parent. What parenting style am I using? Am I the kind of parent who tells my children it is my way or the highway? If you come at this point in time to my house, don't come back. That child will go, especially the Gen Zs. They'll be like, I'm already late, I've over curfew, so I'll just stay out. But you use the right kind of parenting, and most psychologists agree that the authoritative kind of parenting is what works. You set rules with your children because you're communicating with them. You have a democratic kind of parenting. If they break rules, they agree these are the consequences. It's a warm kind of nurturing. But where are you nurturing from if you're never at home? So you must create time to be with those children. Even in communicating with them, it's not about them speaking and you already crafting a response in your mind. It's actually about empathizing with them in their teenage years, stepping into their world to see the world from their worldview. This child is talking about going out over the weekends. They want to be back home at 5. But you, in your own way of parenting, you want them to be back home by 2. But how about extending a little bit of boundaries? If they break the curfew, then they suffer the consequences. So it's about you being there as a parent, in communicating with them, listening to them, and trying to step into their world. Otherwise, you're going to lose your children.
Wonderful. How do you guys feel about the conversation so far? And I don't know why, but so looking at your faces, they were very blank when we started. Right now, everyone looks like there's something they want to say, but I want to bring this first panel session to a close. Is that okay? You guys are not happy about that. I want to bring it to a close, all right? So that then we'll have, in our midst is a person I will introduce shortly, and then we'll then follow up with a keynote speech. Mtanipatia ruhusa hiyo? Si ndio?
Is this a great conversation? Are you glad we are doing this? Who thinks they're glad we're doing this? Yeah, I'm absolutely glad. I'm feeling like I've really missed. Yeah, I know some of you, when you're coming in, you saw some noise. You must tell that I'm not the boss here. They keep me very busy. So they give me my schedule and told me, you show up here, you show up here, you show up here. So who's the boss? Them. Don't you agree? And I also came in when the team was really going through, the panel. I'm thinking this is a conversation we could have all day. Yeah, because this is life. This is life. And I think the one thing that troubles all of us as parents is we want to parent right. We really do. Don't you agree? But I see, I was looking at the panel and wondering, is it a thing that psychologists are female? Predominantly? They are. So I see quite a number of gentlemen in the room. Can we give them a hearty clap? I'm a mother of daughters, and I'll tell you, I tell people there's nothing I've seen as powerful as, for me, when I say something, it's a suggestion. When the dad says something, it's the law. And he doesn't have to experience a lot of, challenge. And I wonder, why does mine sound like a suggestion, When he says, no, we are leaving at 10. Okay. When mom says, we're leaving at 10. But mom, why are you normally like that, But it must speak to the fact that, I guess for my daughters, they recognize that authority as such. But more importantly for me, and I'm conscious to always celebrate the fact that I have a present, isn't it? Present father. And I'll tell you why I'm saying that, just going to the aspects of present parenting, is that I have noted, just because he takes the initiative to drop them to school, pick them, and be around the house, by the way, he doesn't have to say anything else. But for some reason, these girls are the most confident girls in the world. Isn't it? And I'll tell you, they're not young. My eldest is just turning 19. My second one is turning 18. So they're not small. But I can tell you, wow. I look at them and I can see the confidence. So I really do want to celebrate the conversations that are going on today. And the fathers have chosen to be here. But we can't miss the moms because we worry about everything. Everything, the comma, the way I said it, the way I didn't say it, and so on. And back to the platform that is Covered Conversations and why you're here. Welcome, and I take this opportunity to formally welcome you to the Jubilee campus. Jubilee Insurance is the leading insurer in this region. And we are not, and I'll tell you, this is not just about doing business, because many people think it's about business. But these are the conversations that matter. And when we looked at our data and we kept doing what we do, because Kenyans and East Africans have trusted us to make us the leading insurer, that's on the curative side. But we said that when we talked and listened to our customers, we kept hearing a lot of theories, a lot of old wives' tales about why things happen as they do. So we began Covered Conversations last year, and we said we wanted to bring research-backed information. We did not want people talking in the corner. We wanted people to listen to research-backed information. And this is our third one. And I will tell you, the team has literally banged on my desk 10 million times saying we must talk about youth and mental health. So can we give Dr. Brian and the team a hearty clap for this?
Adolescent mental health is so crucial. Why? Because this is an interface between childhood and adulthood. And during adolescence, if you did biology or chemistry, there was something called equilibrium. Equilibrium, there was an arrow going this side and another arrow going that side. So the adolescent period is the period of equilibrium. It's either you are a child or you are an adult. But this is the interface. It can take a very short time and it can take a very long time. But within this period, there are issues. Good things and bad things. Some of us passed through it without any problem, but others had serious turbulence before they settled. But all in all, we expect them to eventually be good adults who can contribute to the society and independent, and they are happy in their lives. So this period must be recognized. Number two, they require assistance to navigate through this period so that they can be competent, they can be able to cooperate, they can coordinate and control their moods. Because some of them, probably those who have their adolescent children, sometimes you pass through the corridors and you are not talking. Yeah, anangalia the other side. As the principal says, some of them would not even talk to you. You're talking to them, but you're talking to a wall. Yeah, or they you call them what? They roll their, you know? Yeah, but you swallow that. So it is just a stage. So we want them to have good characters and also appropriate connections. So you have to balance and help each other so that they can also maneuver that stage and eventually become good adults. Now, clinicians in mental health. I remember my time when we were in medical school, there was not much emphasis on mental health. It was only a 2-week period of passing through mental health. So as doctors, we didn't have much. Once you qualify as a medical officer, there's not much you know about mental health. And that was the training. But later on, that was realized. Then the curriculum included a lot more period, a longer period of mental health training, so that by the time this young girl and boy finishes medical school, after the 6 or 7 years, they can now make a diagnosis of mental health. So the curriculum helped. However, it didn't emphasize so many things, and that's why, yes, they can make a diagnosis, but they may have to refer. The issue of referring a patient. They will refer, but what happens? The caregiver who accompanies this adolescent or the young adult, when they are referred to a psychiatrist or a counselor, they look, but my child is not mad. Because mental health, they only look at the extreme, and the extreme are those ones who have lost it completely. And that's only 1% of the society. The majority are those ones who still understand and those ones who can manipulate their way. Okay? So, after the training, then now it's the psychiatrists who come in, the counselors who come in, the clinical psychologists who come in, and they unravel the problem. Working with adolescents, you don't look at the adolescent at face value. You look at what is behind the behavior, as Mwalimu said, the principal. You look behind the dressing, you look behind what they have said. Because if you don't, then you'll miss the point. And that now comes to the details. For any person dealing with a mental health problem, for an adolescent, must have details. We have categories of patients, and they are the majority of the adolescents who move from one hospital to another, what we call the doctor shoppers and the hospital shoppers. Because the parents are not happy and the child is not satisfied with the care. So they'll move from one hospital to another. And in the process, because we expect them to achieve in school, they are missing out in school and they are not able to catch up. So what happens? Transfer. Transfer this school, transfer to another, transfer to another. And it is always, that school is not good. That school is not good. But the real root of the problem has not been diagnosed. So we are urging us, as the insurers of our health, it would be good also to follow up. When these young people are admitted, how much investigations can be done. So there's a time that we must stop. We say, this problem is not a physical problem. This is a psychological or a psychiatric problem, and call the necessary personnel who can manage that child. Now, once that diagnosis is done, then there is the intervention. Unfortunately, again, as parents, I've brought my child, I'm giving an example. I've brought my child, but I don't want my child to be given medication. So I ask myself now, then why did you come? Because that medication may be there, may not be there. Majority of the times, we don't medicate. As mental health workers, majority of the times we don't medicate. Research, even for the adults, have shown that every person who visits a hospital at any given time, 40 to 60% of the illness is psychological. Which means they are likely to have only one or no medication. But our upbringing is such that when you go to hospital, you must come out with a package of medication, which is not necessary. Our parents, they were used to injections. Ulienda hospitali, ulipatiwa kashindano. Why didn't they give you an injection? Because that was then, but now it is something else. Now, these young people, they have a lot of information, such that by the time they are coming to see us, they know the problem. Sometimes they have overemphasized it. And there are people who are dying because of the Google doctor. The Google doctor, or nowadays it's AI doctor. And by the time they're coming to see us, they have some information, including parents, which is a good thing. But we have to now, as clinicians, we have to separate all that information and package it in a way that it is understandable and that it is simple for the patient. Unfortunately, some of them, they read the symptoms and they apply it to themselves and they start behaving the symptoms. So they come and tell you that I am depressed. And they have read all the symptoms. And what happens? Yes, I'm depressed, but for me, there are symptoms I'll have to exclude, which they don't have. Because one, they are still able to bathe themselves and look very nice, polish their nails, make sure that they look so, they look nice. So that is unlike a depressed person. So we confront. And when you confront, then now they start thinking in a rational manner. So as a mental health worker, we help them to bring the abnormal to the normal, so that whatever they are doing, it is not abnormal. And we emphasize on them behaving normally instead of picking these symptoms. Now, of course, people get sick. They do get sick. But now, when they start picking the symptoms from the Google doctor, you will not know whether it is true, they are truly sick or not. And that also happens at school. Majority of the times, the adolescent has no physical problem. Majority of the times. And majority of the times, they are not mentally sick. Okay? There is the true mental sickness, the 1% I was talking about. There is the true mental sickness, and there is the behavioral issues. Majority of the times, they are the behavioral issues which the parents are not able to understand. And that's why they seek for help, which is okay. Now, when they seek for help, they have already gone through investigations, then we don't have to continue doing the investigations because physical symptoms have already been excluded. So we are working on the mental health issues. The mental health issues are vast, are diverse, from the very serious to the very simple ones. So when you find an adolescent who is saying, oh, I'm depressed, and I think I've used so many other, I've used supplements, I've used what, and now I need medication. I will not go there. We will not go to medication. There are still other ways of managing this problem. Why am I saying that? What are the causes of these adolescent issues? Some had already been mentioned. Bullying is one of them. And there are children who can't even talk about it because there is no space to talk. The principal, at least you gave them space to talk. There is no space to talk. Now, parents are requested to give these young people space to talk so that they can vent their frustrations. Other times, there is a boyfriend involved. And this boyfriend, there are several who have expressed interest and they don't know how to choose. Because there are those ones who just want a nice time. There are those ones who are giving money. There are those ones who tell them the sweet nothings. And then there are those ones who just want their present. Now, how does this young girl with a very immature brain make a choice? They need somebody to help them, isn't it? Principal, you are in a mixed school or a girls' school. Some of you who have been in mixed schools, there is that age of Form 2. Form 2. Now, Form 2 and grade 9. That is the period when these young girls and boys have arrived. They have arrived and they know better than you. You cannot tell them, and they are trying everything. They'll try you, they'll push, and eventually you allow. Now, this is not a period where you beat them. Corporal punishment iliisha at the age of 10 years. But I'm not saying you stop. You can still do that. You must show your authority at some point. Okay? But at this age, when you try corporal punishment, mutapigana. Whether it's a girl or a boy, mutapigana. So this is the age where we negotiate. Let's talk. Let's negotiate and agree. And once you agree, follow through. If they don't follow, then there are consequences. So they must learn that there are consequences to everything that I do. They also must learn that whatever is given to me by my parents is because I deserve, not because I have a right. Because when, let's say you have 2 children and you buy shoes for one and you don't buy shoes for the adolescent, there's a reason why you didn't buy for the adolescent. So they must start working for theirs. So you buy shoes because I deserve. You give me pocket money because I deserve, not because I have a right. Because nowadays, there are children's rights. Yeah, there's one who used to hang it on my face. My mommy beat me, and that's wrong. It's children's rights. It's wrong. Or he used to scream when mommy starts caning him. Children's rights, children's rights. Scream. That's not the way. Yeah, that's not the way. So children's rights, I think we need some review. Yeah, I know some parents also have problems of their own. But it's important now to focus on this young adolescent who is trying to maneuver their path towards adulthood. Other things, of course, they'll engage in high-risk behavior. They'll engage in, as they explore, and then they discover this the wrong way. But we channel them through the right way. When they go wrong, we correct them. It doesn't mean that we overuse, punish them, because even us, we went through the same phase. And some of us as parents, I think we were very bad. And I think it's good to look back at our performance as young adolescents before we can now punish these children. Some even follow what we do. As parents, these children copy what we do. They copy the way we dress. They copy the way we talk. They copy everything that we do, what we call modeling. We model for them. So if we model bad behavior, what do you expect? If we model the way they dress in a skimpy way, what do you expect? I've had fathers and mothers who are substance users, and the boy has come or the girl has come drunk, and the boy is to be punished. How do you punish when yourself you have a problem? So you treat in fact, these children will tell you, but daddy, you also do it. So if I do it, then why are you punishing me? So these are the things that we need to reflect on our lives first as parents, so that we can help these children accordingly. But I'm not saying that parents are bad. All parents are good enough. But there are certain characteristics that we need to be aware of. What we call self-awareness. Self-awareness as parents. Sometimes we even make diagnoses as mental health workers. And we tell the parent that this child has this problem. And you know what the parent does? No, Daktari, you are wrong. I'm going to sue you. It happens. So we are all the time being threatened. But I will stick to my truth. If I'm wrong, then the best thing is to ask somebody else to see this child, so that we can help this child. And no strings attached. I am not against any parent. So we need to make use of the community services that are available through Jubilee insurances, other insurances, so that these children can get help. Mental health is real. And mental health involves the whole person. The way I dress, the way I talk, communicate, my interpersonal relationships, my performance at work and school, all that is about mental health. So it is not pinpoint that, like malaria, you can say there's the malaria parasite. Mental health involves everything. So it's good that even as the mental health workers look at these children, also parents must know their children. I'm emphasizing on this. Parents must know their children, so that they can act as preventers of subsequent mental illnesses, because it is possible. We prevent the ones we cannot, then the mental health care workers can help in managing this problem. Now, on that note, I think I want to stop at that and say thank you for listening. I hope I passed the message. Thank you.
So I want us to conclude this discussion. And a lot of the questions I'm seeing here are going to be answered by these panelists. And a lot of the questions are around what I want us to talk about. So we've already figured out at this point that there is a problem with adolescents. That number two, it's a very good idea to intervene because it will show up later in life. Correct? That one is very clear. Number three, it's already come out that the role of the parent for the adolescent is very crucial. All right? Now, I want us to look at the point where something has already happened. All right? We've been talking a lot of prevention. I want us to talk now, there's someone who's depressed, Or we even want to hear from Grace.
Yeah. So, when they were saying parents lacking involvement in all this, it could waste your time, it wastes your money, and yeah, now we can see the importance of why the parents are supposed to be present and all. So, yeah, we saw a pediatrician. I was referred for an endoscopy procedure because they couldn't really find out what was going on. But yeah, turns out my pediatrician was able to identify. I think now this is a mental problem. And she had some time to converse with my dad at the time, and they asked me so many questions about whatever it is that had been happening at the recent times, about my school, because it was like I come home when it's now time to go to school, the condition now worsens. Yeah, so from that now you're able to tell, the problem could be coming from school or something. So what about school? Yeah, so we were able to be referred to a psychiatrist. A diagnosis was done. I'm sure maybe some few people, or even one or two, you've had these mental conditions before. I was diagnosed with depression, and yeah, there's some medication I was subjected to. Maybe you could not know so much about the drugs and all, but I'm sure some few people hapa when you wamekuwa diagnosed na depression, you all know of fluoxetine. Yeah, so yeah, I was able to get treatment, and my parents were now able to know. They learned, even at this age, if I call my dad at 4 a.m. in the morning, he's gonna pick up and try and find out what's really going on. Yeah, and it has happened even this year. Just me calling him early in the morning, and he was able to identify something is really wrong. She needs to see a psychiatrist. And yeah, I would love that the parents are able to, understand that. Then for the young people, I think from that, I feel like the strongest thing you could do, sometimes we feel like us being strong means not actually involving people in whatever thing it is we are facing, not seeking for help and all. We think when we are able to make it out on our own, that is strength. But I can assure you, the strength that is gonna show is when things are not going right and you're able to come out, you're able to speak about it to your parents, to your mentors, to your peers, any person who is experienced, or rather who you would feel would actually be there for you. That's the strongest thing you'd ever do. Yeah.
Thank you. Let's give her a round of applause. I have seen a question here, and I want to direct it to Dr. Josephine Omondi. How do I support an 18-year-old going through depression as a parent?
An 18-year-old is an adolescent, but there are many factors that could be. The question is that is depressed. Yes. Yeah. Oh, they are depressed, diagnosed by a clinician or self-diagnosis or AI diagnosis. Which one? I mean, I need to confirm that diagnosis. Remember, I told you that majority of the problems in adolescent is not the morbid depression. The circumstances around the child are usually the problem, not the morbid depression or the morbid anxiety. There is something around the child that is contributing significantly to the problem. So the best thing, go to see a counselor or go to see a clinical psychologist or even a psychiatrist to unravel and make the right diagnosis before you start any treatment. Thank you.
Wonderful. This will go to Victoria Rika, and it's about parenting. In parenting, how do we handle different kinds of parenting? One parent says this or gives rules, the other one downplays the rules or is not strict. The strict parent ends up being the quote-unquote bad parent. The kids already know and can read the parents, so they take advantage. That is the first part of the question. The second part of the question is handling separation of parents, especially for teens or kids, and is co-parenting possible?
Well, that question always comes up because different parents, based on their personalities, on their backgrounds, they always parent differently. But we also say that you cannot be having just one style of parenting, even you yourself. Yes, we say there are about 4 parenting styles, main parenting styles. But at some point, you can also be, let's say you're an authoritative kind of a parent, so you use the right kind of parenting. But at some point, you'll find yourself, if the consequences are not too high, then you can be permissive at some point. Maybe the child wants to take ice cream before dinner. Really, it doesn't cost you too much in terms of anything, so you allow that to happen. So in that particular aspect, you're a permissive parent. But now when it comes to the two of them, one is very permissive, the other one is very authoritative, the children will always know who to go to for what. Because they know this parent will say yes, the other parent will be no, the rules must be followed. So the children then become very manipulative because they know the weak parent. Let's call them the weak parent. So how to go about it? The parents must be so self-aware to know this is my personality, this is my background, and this is my main parenting style. And they must come to a consensus, the two of them. They must come up as a united front to show that this is what goes. These are the rules that we apply for whatever situation, but they must come out as a united front. So they must go back to being self-aware themselves about how they parent and the consequences of their parenting. So how about them being self-aware to the point where they come to a consensus that this is the main parenting style that we will use and being consistent about it? Because children pick, but last time you allowed me to do 1, 2, 3, so why not this time? So consistency must also apply. On the second question, co-parenting can and does happen, but it goes back to what were the factors surrounding the separation or the divorce? How was it handled? In most instances, I think about maybe 80%, the divorces and the separations are very acrimonious, especially within our setup. You try sabotage anytime the other parent wants to take the children to wherever, there's always bad mouthing. But if the two adults have come to a point where they cannot live together, they need to give the children the assurance it is not about you, the children. You're not the reason why we have separated. It is about me and my husband or me and my wife, and we will handle our problems, but that does not diminish the love that we feel for the children. And if we are mature enough, we will still take care of our responsibilities. So as parents who have decided to separate, do not badmouth your partner in front of your children. Do not sabotage whatever it is they're trying to do for the benefit of the children. Let the children be so secure, because sometimes when parents separate and one of them is living with the children, if, for example, you go on safari or you are late for work, you don't call to tell the children you're coming back, they get what we call some anxiety. Has mommy also gone the way daddy left? So also communicating to your children, telling them that you're there, you're with them, you're supporting them, and also trying to show the good aspects of the other parent. So co-parenting does happen, but they have to be very, very mature about it. If you feel you cannot co-parent, then go for couple or group family therapy, where then you can get the assistance from a professional on how do we parent. We can barely stand to be in the same space with my ex or with my ex-husband or my ex-wife. How do we co-parent? And for as long as we have children together, then somehow we'll always, be in each other's hair. So how about we make it easy for each other by being mature about it? Sindio. So co-parenting can and does happen.
Thank you, Victoria. This goes to Dr. Rose. And the question is actually titled Suicide. So one, they would want to know what is the cause of suicide. How do you recognize the signs? How to help a suicidal teen or child? And how do you handle if this teen is very silent? I think it's many parts, many questions, but you could talk to us about.
Yeah, suicide. Suicide is a big challenge, and especially among adolescents. Why do people die by suicide? Let me say this. People don't wake up to want to die.
Correct.
No, they don't wake up to want to die. It's been a journey. Yes. And more often than not, factors that would resort to suicide, number one is depression, major depressive disorder.
Yes.
Number two, it could be substance abuse.
Yes.
Number three, it could be what we call impulsive behavior. Yes. We've had someone say, if we separate, one of us has to die, just acting because of what you are feeling. Yes. And I think it's important for us as parents and teachers to take suicidal language seriously. Growing up, if you told your mother you want to die, what would they do? They'll give you the option. And then fine. You try that now. You try that now with our current children. They will actualize it. And we'll be left tormented. We'll be left tormented. So let us take suicidal ideation, someone thinking about suicide, about dying. Let's take it seriously. And one of the ways you can pick the telltale signs is someone speaking in a manner that seems hopeless. I'm not good enough. If I die today, who will care? Or if someone starts giving their precious items. I love this watch, all of a sudden I give it to dog. That's already a language that someone could be planning something. Because more often than not, when someone dies, people are like, what didn't we see? You saw, but you did not pick it. Now, when a teen is withdrawn, let me say the red flag that someone is not okay is change. Change. This teen used to talk a lot. All of a sudden they have withdrawn. This teen used to shower, she loved doing makeup. Right now she doesn't care. She doesn't even shower. Any change you find with that teenager or any human being is a red flag. That is not okay. When they go silent, at the end of the day, it's the child you want to help. Look for a significant other. Someone they trust. Someone they are very cordial with. It could be a class teacher. And that's why teachers come in very handy. It could be an auntie. It could be the grandmother. Go through them and get to know, is there anything wrong? And once you get to know what is wrong, please don't be mad and tell your child, why didn't you tell me? Don't. Celebrate your book, even if it came from a different source. And if it is an issue that needs to be addressed, let that child see a counselor. Because counseling will unravel. And there are moments even they don't want to talk to somebody, but you tell them, can you see a counselor? And they say yes. Let them go to a counselor. The counselor will help them unravel what they are going through. And something else I want to say, Doc, you can't help a child outside the family. You can't. If I have to see your child, you're also in that mix. At some point, because some stressors, what is causing depression in this child, it's at home. So I have to have a family session. I have to have a session with you, mommy, separately, or you and daddy together. Because after I counsel that child,
I won't live with her. She'll come back home. And so if the environment is not conducive, I will not help that child. So it goes like that. But please look for a significant other who can reach out to the child, and after that, you can get. And when you get to know why, sit them down, appreciate that they have talked to somebody. Then the conversation can continue.
Wonderful. That makes sense to us? Great. So I want us to do one round where they each give us their parting shot. So I want to start with Chris. Give us, in 10 seconds, your parting shot to the people who came to listen to you.
Okay, so I guess him saying the people who came to listen to me, I'll have something to say to the parents, I'll have something to say to the young adults and the adolescents, yeah. So for the parents, we are grateful to these people that they're actually inviting us to these spaces where our teams are actually here for you to listen to whatever it is that they are going through, or rather whatever it is that they are facing. And my parting shot for you guys is that, just what we said the very first time, whatever it is we were putting emphasis on, be present for them. Be present for them. That is the most you could do for them. Just be present for them, and you have to understand they are healing from whatever it is that they have gone through. I know from the speakers, or rather from the panelists, something you can take is that this thing is multidisciplinary. It's not the role of the psychologist, it's not the role of the psychiatrist, it's your role. As a person, as a parent, it's a multidisciplinary thing. So I hope, because I said, even for the youth, you just speaking, it will do something, and it's the strongest thing you could do. So yeah, I just hope we all understand that we are part of this. We are part of actually getting to see a better approach for things to do with mental health. Yeah.
Thank you. A round of applause. Thank you. Ms. Victoria?
Thank you, Daktari. I think the parting shot would be for us to be so self-aware that mental health starts with us. If I'm not a healthy parent, whether current, potential, then I will not be in a healthy space to parent. So what am I doing for myself at an individual level is to do things like self-care. How well am I sleeping? What am I eating? Am I exercising? Do I take time off to unplug even from digital devices in terms of self-care? Because we say you cannot pour from an empty cup, and you can only give the level of what you have. So take care of yourself first. If you realize, for example, you have mental health challenges, if you pick up on any mental health challenges in your children, your family, then the earlier the diagnosis, we say the better the prognosis, the outcome. Thank you.
Thank you, Victoria. Round of applause.
For me, it's the parents. If you want to be in your children's memories, be present today. If you want to be in your children's memories, be present today. Thank you.
Yeah, thank you very much. I have two parting shots. One is I want to be the late Professor Wangari Maathai, that let's not interfere with nature. Children need both parents. And let's not interfere with that. Well, let's try, we must prepare to be a parent. If I'm not ready to be a parent, we prevent being a parent. But we must be available. When the environment is abnormal, the child also behaves abnormal. When we correct it, the child resumes normality. Number 2, there are 4 common problems that these young people face, or that I see. 1, serious disturbance of conduct. Those who self-harm, they cut themselves, or they threaten suicide. That has already been talked about. Then the psychosomatic illnesses and learning disabilities. We are seeing many children with learning disabilities which should have been picked when they were young. But when they are older, they start manifesting with behavioral problems. And once you evaluate, you realize there's a learning problem. Now, let's not say mjinga kama mama yako or kama baba yako. We look at it in a very rational manner so that these children can be helped. It is good to pick them early rather than later when there is maladaptive behavior. Thank you.
Wonderful. You guys enjoyed that conversation?